One, we are live.
Hello, good morning, good afternoon, and good evening. Thank you, viewers all around the globe. This presentation webinar is going to be telecasted in 63 countries around the globe. This webinar is being conducted through the platform of Asia Pacific Hip Society, which is a section of APOA. APOA being one of the largest orthopedic societies in the world. Our previous webinar had been very successful and there had been lively discussions. 2,500 viewers in the last few webinars. I'm grateful to top faculty around the world, from Australia, from UK, from Malaysia, from India, who are going to participate. We're going to do a lot of discussion. This webinar is on tips and tricks of cemented hip arthroplasty. This is going to be an evidence-based webinar. This is not going to be influenced by industry presentation. I'm extremely grateful to Professor David Choon, Professor Nicholas Budhiprama, and Dr. Jamal Ashraf, who've been very supportive in supporting Asia Pacific Hip Society and making this a wonderful experience. We've had a few last-minute faculty drop out because of unavoidable reasons. And I'm extremely grateful to the General Secretary of Asia Pacific Hip Society, Professor Abhay Elhence. He's going to moderate the session, and I'm going to pass the mic to Abhay Elhence, and he is going to introduce faculty, and we will start a presentation, and then we'll have debate session. And finally, we will have a few case discussion and panel discussion. So over to you, Abhay.
Thank you so much, sir. And very good afternoon, good morning, and good evening to viewers all around the world. My extreme gratitude to our wonderful faculty. We have a galaxy of 5-star surgeons with brilliant academic experience and surgical experience behind them. So none other than Professor Ross Crawford, who is known around the globe for his phenomenal work on cemented total hip arthroplasty. Dr. Fatih from Turkey, who is another doyen and a brilliant surgeon from Turkey and representing the Asia Pacific region. And we have none other than our own Professor Shubranshu Mohanty. He is a brilliant surgeon, and we call him the Javed Parvizi of the East, has amazingly good work on infection. So welcome all faculty colleagues. Unfortunately, Nikhil and Dr. Chris Wilson could not join us for some last-minute pending and very urgent issues. So we will miss them, but we will start our webinar anyway. So may I invite Dr. Crawford to present his talk on cemented total hip arthroplasty, the Australian experience.
Okay, perfect. Thanks for the introduction, and it's an honor to be part of this program. And I'm sure between us we can fill in the voids of the missing people with some chats and tips and tricks. I do have a conflict of interest. I am a design surgeon on the Exeter hip replacement. I have been for 20 years, but what I'm going to present to you is essentially data. And we heard that this is going to be evidence-based. This is evidence, and it still stuns me that particularly in Asia Pacific, the data is denied. People just do not do what they should do. It makes no sense to me. It's not the right thing to do by your patients, and we've got to start to use the data. So let me give you a bit of data, and then I'll elaborate on some of those thoughts. This is not really relevant to this talk, but in some ways it is, because for whatever reason, the world looks to the United States and says, what do they do in the United States? They do lots of uncemented hips. We should do lots of uncemented hips. This is one of my favorite slides of the last 2 years. If you look at the screen, the USA spends $10,000 per capita on healthcare, and its life expectancy has gone nowhere in the last 20 years. Whereas every developed country in the world spends less and lives longer. And there's only one logical conclusion. There are some gun deaths in the US, but essentially their healthcare system is terrible. And what they do in the US is not good quality healthcare. And we've got to stop following the United States in their philosophies around healthcare, and in particular around total hip replacement. That said, I will show you in my talk that cemented stems are the way we should be going in all patients. And even the Americans now are starting to change. And every registry paper in America is finding the same thing. But APAC, much of the world, is still stuck in the past. I'm not really going to talk about cemented cups because much as I love them, and I do a number of them, it's a bit of a death spiral. The good news is hybrid hips are starting to just climb up a little bit, and we're seeing a bit of a turnaround in the use of cemented stems with cementless cups. So that's what I'm going to concentrate on this evening. This is a hybrid hip replacement. You can see it's a cemented stem. It's reproduced the offset, slightly long, uncemented cup, and that's what we're going to concentrate on. And what you'll see here, and I'll elaborate further in some graphs, is in no age group do cementless stems do better than hybrid stems. So you can see here, hybrids do better in the young. As you get a little bit older, hybrids do well. And when we get over 75, you can see that the hybrids and the cemented are highly significantly less likely to be revised than the cementless stems. And after 15 years, that's 50% more likely to have a revision of your stem, of your hip, if you have a cementless stem than a cemented stem in over 75. But there's no age group where cementless stems do better than cemented stems. So this myth about cementing or cementless stems in young people is just that. It's a myth. You can see here, patients under 55, just to highlight, there's absolutely no difference in the young. And in the old, it's terrible. And it's early revision from fracture, and it's ongoing. So a lot of Asia Pacific, there's a lot of osteoporosis, there's a lot of elderly people, but the vast majority of implants put in are cementless on both sides. You've got a population that often has to pay for their implants. The technology is more expensive. It has a higher revision rate, doesn't work as well. It's just not the right thing to do to your patients. I've said it 1,000 times. I'll say another 1,000 times. Maybe one day people will start to listen. Another important point is that cemented stems are not the same. So we can bundle them all together, but when you actually come down and look at the detail, you can see something like the CPCS, which is a very commonly used stem from Smith & Nephew, has a 20% 15-year revision rate. Of note, the Karai, which we'll know cementless, has an 8% revision rate, and Exeter Trident's 5.4%. So you can almost halve your revision rate if you choose the right implants. I know David's going to talk about this a bit more, but just to highlight from Australia, fractured neck of femur, under 70, Not a lot of difference. The cemented does best, the hybrid and the cementless does worst in under 70s, which would be your very best patients who get a total hip under 70. And then when you get over 70, it's double the revision rate in your uncemented stems. So it's the wrong thing to do to your patients. You can see here, you probably should be cementing your cups as well, because that's double. Again, just to highlight how good cemented technology is in fractured neck of femur. And that's what you'd want your mother to have. That's what you do to your patients. There's a great conflict there, and people need to start becoming more cognizant of what the data tells us. This is the under 70s, and you can see it's still a massive problem with uncemented stems. That's the greater than 70s. And it's fracture. You break femurs. It doesn't make sense to knock a really big piece of metal into a broken bone that's really brittle as hard as you can and not expect it to break. And if they break, they die. It's a revision in a fractured neck of femur is a pretty much a death sentence. So you're killing this number of patients if you use uncemented stems in fractured neck of femur. The other big change, and this is not data, but this is just 1 minute of cement and cement revision. So we no longer need to remove well-fixed cement. So there's no problem using cement in young people. With a well-fixed cemented stem with an acetabular problem, you knock the stem out, revise the cup, and cement a new stem into the old mantle. And no surgeon in Australia, even the strongest uncemented surgeon, now removes well-fixed cement. So if you see well-fixed cement, you should not remove it and try and put in a long uncemented stem. Here's a case. That's what it looks like. Cut the neck, cement your stem in. It takes 10 minutes. It's a very, very straightforward revision, and it's got extraordinarily good results. So in conclusion, in no age group does a cementless stem perform better than cemented. No age group. In patients over than 75 and all fractured neck of femur, cementless stem should not be performed. And these are the same results in every joint registry in the world. Not every cemented stem is the same. And why would you choose something that's more expensive, has a higher revision rate, and is harder to revise as the stem of choice in the Asia-Pacific region? Thank you.
Thank you very much, Ross. And thank you for sharing evidence base. I must congratulate you on being a designer of a very successful implant and sharing a data and evidence. But I would ask you a question. So the data supports that cemented stem are successful in all age group, and especially in patient above 65. The question is, why have we not been able to pass on this message to young surgeons across the globe? Is it the poor marketing? Is it the industry who've been overwhelming in sending a message that what Americans do is great and we should all follow? That's a question to you, Ross.
Yeah, look, it's a bit of both. And interestingly, in Australia, the young surgeons are taking up cemented stems. It's the surgeons of my generation that have, a lot of them are in the pockets of companies. You know, an implant company makes a lot more money selling a cementless stem than a cemented stem. And surgeons blame the companies, but we are the gatekeepers. We are the people who make that final decision. And we've got to look at evidence and say, no, I'm not using that. It's easy. It might take 10 minutes longer. Do you care? Is your life that valuable that 10 minutes of your time gives a patient a 3 times higher risk of fracture of their femur? If you think that, you shouldn't be an orthopedic surgeon. So we can't blame the companies. It's us. It's the profession.
Any quick comments from the faculty before I take some questions? There's some really interesting ones which have come in. David, Dr. Shahzad, you're all cemented guys today. Any quick
I'll
comments?
tell you the thing with uncemented implants that young surgeons like. You can put in the real implant, you can mess around with it. If you don't like the position, you can just whack out the implant and reseat it, and then you're fine. If with cement, you have one chance. You have one chance only. If you don't get it right, it's an instant revision on the table. Thank you very much. And so at the end of the day, if you want to do a cemented implant, you better be good at doing it. You better go follow the right guru or the person that teaches you how to do it as well. Charlie wouldn't let you do a total hip unless he had certified you at the beginning. And that everyone in that era did very well. Beyond that point, everyone didn't get the results that Charlie did. And if you look back at the statistics for the flat back, which was the original Charlie hip, those Charlie hips have done very well, apart from those that fractured. Those were actually very good series. And
Dr. Shahzad, a quick comment from you. A very interesting opening discussions and thoughts. Before I take the first question for the day, Dr. Shahzad, any quick comment from you?
Thank you very much, Shahzad. I know you are on call and you're sparing time, and we welcome you to this Asia Pacific Hip Society webinar. Thank you very much.
My own practice has changed in the last 5 years. So we started off doing mixture of both, doing cemented and uncemented stems. Having had training in Wrightington, so I was pretty much, can be said, spending a year with Professor Paprosky, Bodo Purbach, so was very well trained in terms of how to cement a femoral stem. Having worked in Canada, having worked in many centers in UK, I have not seen the vigorous surgical technique of cementing anywhere else what is being taught in Wrightington. Having taken up the practice of a surgeon who was Exeter trained in Worcestershire, and what we noticed 10 years ago, most of the revisions, what they were facing were the implants like Stanmore and Charnley's. Having looked at his practice, where a lot of hips with Exeter stem are more than 12, 15 years down the line, we hardly see the cement disease, which was the main reason for promoting uncemented stems, and cement disease was coined in America. So looking at my own practice, where I do about 200 hips a year, I have shifted back to doing more uncemented stems as compared to uncemented. And I will show you in my talk that my own data shows no intraoperative fractures with cemented stems, but 1 or 2 fractures with uncemented stems, which I had to revise. So in a female or osteoporotic bone, and the uncertainty which exists in the cancellous bones in many femurs, I do not see that the uncemented stem performs better than the cemented stem. So you really have to be convinced that why you have to do uncemented stem. I'm not against uncemented stem. I think uncemented stems are doing well as well. And my clinical practice is with using acrylate, but I know in UK, the most second popular stem is Corail, and it generally does well. But another surgeon in my hospital who does about 300 MIS Corail hips, he gets about 2 or 3 out of 100, which have not bonded Corail stems. So again, you have to ask the question that if he had done cemented stem, he would have not had those revisions. So going back to the talk, the first talk, really, if we look at the data goes in favor of cemented Exeter or polished taper stems design. And polished taper design has outdone the Charnley composite beam design. And if we are using the modern cemented polished taper stems, the results are excellent in the NGR. And that's why there is a trend going back to more use of cemented in UK as compared to uncemented. That's what we see in my practice and in United Kingdom.
Thank you so much, Dr. Shahid. Brilliant points as a start of comment. So we have some very interesting questions, and may I ask Ross to address some of these, and I'll subsequently come to you all. So what, according to you, Dr. Ross, there is a question, was the reason for success of the Charnley total hip arthroplasty, which has a 40 plus years experience?
Yeah, the original Charnley was a polished tapered stem. It became matte when it many years later, but the original Charnley was a polished taper. There've been 212 different Charnley stems over the years, and when it became a vacuum-machined or a roughened stem, its results were disastrous. But the original Charnley was like an accident. It was a polished tapered stem, and Charnley actually
Can I jump in there? I'm sorry, and say actually there's a wonderful paper by Ian Learmonth and Desmond Dow that illustrates this, and they published it in the 90s. And really, that message hasn't percolated down there. You're right, Ross. Your own research shows that there is a difference between the two types of stems.
Okay, another question, and may I ask David to come to this? Why did Charnley hip have a longevity of 40 plus years? Was taper corrosion not present, or was wear not important with these old generation implants which have lasted more than 40 years?
There is no taper in the original Charnley. It was a monoblock. And I think that's part of the success.
Yeah. Sure.
It had pretty crap poly, and most of the failures were due to poly wear. Charnley got his sums right. He decided to use a smaller head, and this lasted longer in weak poly. And actually, I'd like to take up a point with Ross. Ross, actually, the world thinks that hybrid implants are better than all cemented implants. And that seems to be because the acetabular component seems to last longer. But I believe, you can confirm this because you're Australian. I believe that it's because most of the hybrid implants that came about with highly cross-linked poly. And for the older generation of all poly implants, actually the poly wasn't so good. And so therefore you got more wear and you got more loosening. Would I be correct in assuming that?
They've actually excluded those from the registry now. So it's only highly cross-linked poly cups. That's why the cemented cups don't go out that far. But look, David,
okay,
I'm with you.
So then the cemented cups on those registries you're showing actually I seem to be doing better, don't they? than the cemented cups.
We're not going to. The thing is, pick your battles. If you're going to, I'm not going to make people change to cementing their cups. It'll never happen. We need them to cement their stems first, then we can have the conversation.
Dr. Shahzad, any quick comment on this?
Dr. Mohanty,
in my own hospital, we still do cemented cups, but my own practice is 80% hybrid hips. But I think there is a role for cemented cups, but I think discussion, as I say, are we short in time, then we move forward, we can come to it.
Yeah, we'll take a quick comment from Dr. Mohanty, sir, before I just touch upon the next question if there is time, or maybe we can take it later.
Yeah, just to add the success of Charnley stem, the technique, Charnley's technique of pressurization was probably better due to, number one, Charnley stem was a bulky stem. The stem itself was providing good pressurization. Moreover, he was going through trochanteric osteotomy, and through the trochanteric osteotomy, the whole femoral canal was exposed. And with the thumb pressurization, the pressurization was much better. These are the two factors which are adding the longevity of Charnley's stem, primary hip arthroplasty.
Thank you so much. And may I invite our next speaker, Dr. David Choon. And David is going to talk us through cemented hip arthroplasty for neck femurs. All yours, David.
Thanks, Abhay. I hope it works. Thank you very much, Shahid, for inviting me to give this talk to the APHS. It's to do with the use of total hip replacement in fracture neck of Fema. As usual, I would like to declare my bias in this area. I personally believe that a fully cemented total hip replacement works better than almost anything else. And you've already heard me say that. I also believe that we shouldn't let junior people, both anesthetists and surgeons, operate on our sickest patients, our oldest patients with hip fractures, because the results will be disastrous. And when things go wrong, we are the ones that have to pick up the pieces. I began talking about this subject around about 2006, and around then, the Cochrane collaboration had sunken their teeth into all the different forms of treatments for hip fractures. And of course, they compared internal fixation with arthroplasty. I would ask you to note the name there, Martin Parker and Kurinchi Kurusami. And actually, Parker is quite an authority even today on the intracapsular hip fractures and their and how we address them. In those days, actually, they looked around and they found only 19 trials involving about 3,044 participants. But those trials were really very difficult to interpret, as there was quite a lot of selection bias. Only 3 trials did not have a major selection bias. And to make matters worse, many of the trials in which they looked at Hemi Arthroplasties used uncemented more prosthesis, which we know today does not function quite as well as the fully cemented Hemi Arthroplasty. The conclusion of the study was that if you just looked at length of surgery, operative blood loss, deep wound infections, need for blood transfusions, and so on, actually internal fixation did better than arthroplasty. However, patients who had internal fixation had a significantly higher reoperation rate, although there were no definite differences in mortality or morbidity. They had the impression that cemented arthroplasty tended to do better in terms of pain than with fixation, but given the nature of the papers they studied, given that they were quite biased, they could not conclude that this was the case. So they suggested that further studies should concentrate on better reporting on the final outcome measures and better patient selection. Round about that time in Mayday Hospital, this is another good paper that was published, again comparing 2 types of Hemi Arthroplasty and total hip replacement for subcapital fractures. This is ORIF and more Hemi Arthroplasty and total hip replacement for subcapital fractures. And as expected, 25% of the internal fixations were revised. Actually, almost the same number of Hemi Arthroplasties and total hips dislocated. However, the Skinner group concluded that total hip replacement resulted in the least amount of pain at 1 year and the best mobility, whereas Hemi Arthroplasty was the worst in these respects. Gebhardt and Emsutz also reported something very similar. This is the one where they compared 2 Hemi Arthroplasties and 1 total hip arthroplasty for the treatment of subcapital neck fractures. As you can see, the numbers don't quite match up, so it's not a very randomized trial, and you'd be left to draw your own conclusions as to the validity of the results. The patients were pretty similar, and after 56 months, actually, they discovered that the patients who had a hip replacements had a lower revision rate and better scores and results. Around about that time, people used to say that the cartilage is good, so why should you replace it? Why should you go and dig this cartilage out because it's actually doing very well. So this is a very interesting study done by Deldorf and Hicks and reported in the JBJS in 1995. What they did was to look at retrieval specimens of the acetabuli when hips were revised from Hemi Arthroplasty to total hips. And actually, they discovered that there was a age or time-dependent change in the histology of the acetabulum, such that at 5 years, all the 6 cases beyond 5 years that they revised actually had no more cartilage left. So cartilage is no longer an excuse for going to do a Hemi Arthroplasty. But actually, all the data that existed up to that point really wasn't very good. And so now the Cochrane collaboration are looking at new research to determine the correct answer for this. This was what happened when I looked up this research last year, but at the same time, I found this. This is a paper by Mohit Bhandari, reported in the New England Journal of Medicine in 2019, comparing total hip arthroplasty and hemiarthroplasty for hip fractures. It's a huge study, 80 centers, 10 countries, Canada, all the way down to South Africa, 1,495 pre-morbidly ambulant patients, 24 months follow-up, and then, you just looked at revision, deaths, and so on. So these are the things they looked at: dislocation, fracture, implant exchange, implant removal, implant adjustment, and any soft tissue procedures. All the reports were studied by a central adjudication committee, and as were things like deaths and the scores, WOMAC, EQ5D, SF12, and TUG scores. So you can see here that this is the graph they came up with. In the group of patients who had hip fractures, the hemiarthroplasties at the beginning probably had less of a revision than total hip arthroplasties, but these are actually just procedures. They're not quite revisions. So if you had a closed reduction, that would have counted as a revision on this scale. And if you study closely, actually, that's exactly what happened. Close reduction of hip dislocation actually has the highest number of cases for total hip arthroplasty, and is almost twice the number of hemiarthroplasty. And so you say, well, okay, great, we should use hemiarthroplasties for patients with hip fractures. But the point is this, actually, if you look at full implant exchanges, there are more than twice the number of full implant exchanges in the hemiarthroplasty group. Now, those of us who have done close reductions of hip dislocations in patients with total hips don't have much of a problem. I would actually venture to say that if you try to reduce a hemiarthroplasty, it's a lot more difficult than reducing a total hip arthroplasty. But, a full implant exchange is a very serious operation. And if you're going to do it in somebody, it's going to impact them far more than actually a close reduction of a hip dislocation. So yes, hip instability or dislocation is listed under minor endpoints. I would list full revisions under major endpoints, and in that case, a total hip wins every day. If you go to Australia and you look at their sub-report on partial hip replacement, then you end up, I have to shrink this so you can see better, that there are 3 types of monopolar hip replacements used in Australia: the Exeter trauma stem, the Austin Moore type, and the Thompson type. The Austin Moore type and the Thompson type are both decreasing in incidence, such that by 2020, the polished tapered stem, monoblock or more modular, actually almost takes up 90% of all unipolar prostheses in 2020. When you look at the use of cement and cementless implants for this group of patients, actually the cemented implants for unipolar replacement does better than the cementless, and the cementless fails at a very early stage. Although by the time you get to about 18 years down the line, there isn't that much difference between the two groups. If you just look at various implant types, osteomorph cementless, osteomorph cemented, the purple line and the green line, actually probably it's the same thing. The osteomorph cementless fails earlier than the osteomorph cemented. And best of all is the yellow line, which is the Exeter trauma stem, which is a polystaple stem, and it has the least revision rate. So because of that, and because of other things that people feel that bipolars are better, the bipolars are coming up, and any kind of monoblock or modular is going down. Interestingly, that if your patient's under 75 and you do a unipolar monoblock hip replacement, actually they don't do so well. If they're over 85, they don't seem to mind so much, I guess because their demand of use is much lower. However, if you look at the bipolar group itself, look at a figure of 10% revision at 17 years. That actually compares very favorably with the treatment of fractured neck of femur with total hip replacements in the same registry. So I would venture to say that if you decided to do some kind of hip replacement for a patient with subcapital neck of femur, you could probably begin with a cemented polished stem and a modular bipolar cup, so that if that did not work, you could then proceed to revise just the acetabulum, which is generally what happens in the Australian registry. Now, that's just what we think. This is what the geriatricians think and know after. I mean, I've read this paper. It's a fantastic paper. They've looked at all the evidence out there, all the papers, and they put them into a summary for their own reading. And I would highly recommend you read this, because references are really very good and gives you an idea into how you should really be going forwards. So they conclude, obviously, that hip arthroplasty is becoming more common in patients with severe osteoporosis. Excellent results have been achieved with both cemented and uncemented femoral implants. However, periprosthetic fracture is far more common in uncemented femoral implants. That's because with the uncemented femoral implants, you're trying to fit the patient to the implant, and the patient with a stovepipe femur will never fit the implant. You're going to have to put something huge in there, and it's going to crack the femur when you put it in. Okay, so you should really think many times before you use an uncemented prosthesis in a patient with poor bone stock. They also say that when a THR is performed for fracture, dislocation rates have been worryingly high. And that tends to be true with older patients and patients with less preoperative mobility. So in this group of patients, you really aren't going to get over the problem, whichever implant you use, actually, or whichever methodology you use. So I would say that you should send it to the best surgeon. And when I was training, they say, well, this case is the one you should send to your worst enemy. Thank you very much again for inviting me. Thank you, Shahid, for the great honor.
Thank you so much, David, for your pearls of wisdom. And can I quickly just take you all through a set of questions? So if you were all to look back at your practice and tell us what you would do for a patient less than 50, 50 to 70, and or maybe 50 to 75 and more than 75, then what would the choice of your hip be? So starting from Dr. Mohanty, can I have a very quick response as to how you would go in terms of a fracture neck femur, in terms of a hip in less than 50, 50 to 70, and more than 70 years?
Yeah, less than 50 fixation, 50 to 70 go for total hip. Until 75 I do total hip. More than 75 I would go for bipolar.
David, what is your practice? for your neck?
I'm totally biased, Abhay. I'm just going to use a cemented, total cemented polystem in every case.
Sure. Dr. Shahzad? Dr. Shahzad, can you hear me? You're muted, Dr. Shahzad.
Hello?
Yeah.
Yes. My own assessment, whether I am going to do fixation in a younger patient, which could be as young as 60 with a good bone quality, and because a trauma surgeon in me, I try to fix those if I think in my practice the results has been good. So if the bone quality is good and the fracture is minimally displaced, or in some cases even displaced fractures, I would go for fixation in patients who have a very good bone quality. In terms of if I have to use hip replacement, again, not specifically with the age, again, I will look at the bone quality, looking at the x-rays, anatomy, acetabular anatomy. In hip fracture scenario, I tend to favor cemented excited stem. In a lot of patients, I will still think you may have a hidden fracture which is extending, and you're trying to put an uncemented stem, and you're likely to extend it, and there is an osteoporosis while that fracture has happened. So majority of our patients still will have osteoporosis, weak bone. That's why they resulted in fracture. So in my view, cemented stem is the best. So I really have to convince doing uncemented, which I will do in a very good bone quality, type A femurs, and I'm convinced intraoperatively that everything will be safe. I won't do it on the basis that uncemented stem performs better. In my experience, in my practice in last 18 years, cemented stems have low infection rate, low intraoperative and long-term complications. So 80% of my patients will get cemented stem, and possibly uncemented or cemented socket, depending again on the bone quality.
Okay, thank you. Dr. Fatih, quick answer to less than 50 to 75 and more than 75. What is your practice as of today on the cup side, on the stem side?
Sure. The criteria for me is not the age itself only, but the bone quality again. And as the bone quality raises, I prefer the uncemented total. And if the patient is an elderly patient, then it's Hemi Arthroplasty. And usually the elderly patients have less bone quality, so I use cemented for those patients.
And you would do a total hip even for the more than 75 years?
No, yeah, Hemi Arthroplasty. I use Hemi Arthroplasty for those patients, on the elderly patients. Yeah.
Okay, Ross, your take, you're the master. Final comments on what you would do, 50 to 75, more than 75.
Yeah, look, if you have a fractured neck of femur, unless it's a high velocity road trauma, you have poor bone. You don't spontaneously break your femur unless you're an alcoholic, you've got osteoporosis. So every single person needs a cemented stem. And if anyone here says they're going to use a cementless stem in a fractured neck of femur, they're denying the data. It makes absolutely no sense. And the decision on hip replacement versus hemi arthroplasty is all the international guidelines. You've got to be a community ambulator and living independently. You get a hip replacement. They're the indications. Age is irrelevant. If you're 90, you live in your own home, and you walk with a single stick and you go to the shops, you get a total hip replacement. If you're 50, you're an alcoholic, you're demented, and you get a hemi arthroplasty, but it always has to be cemented. No one has good bone who gets a fractured neck of femur. And the comments around that are factious.
Very clear messages. Thank you guys for your messages. I have a question. Would any of you use a dual mobility cup for an elderly patient with a neck fragility fracture? Can I request Ross to take that?
Look, we're actually running a big study in Australia to look at that. Our registry suggests that a 36 head is as good as a dual mobility for dislocation. So we should know the answer to that in the next 6 to 12 months. But my feeling is I'd rather use a large femoral head than a dual mobility if possible. But I'm very comfortable with a dual mobility cup.
Okay. Dr. Mohanty?
Yeah, if it is a large head, then there is no issue, as Ross told, that if it's 36 head, that's fine. But the problem is, small Asian females, small height Asian females, their copy size is smaller. In those kind of cases, I would prefer a dual mobility in case of fracture neck femur, because that gives me a better stability.
David, and then we will take our own president's opinion. What is your take on this, David?
Sorry, I don't quite understand the question, Abhay.
So would you do a dual mobility in an elderly patient with a fractured neck of femur?
I've used dual mobilities. They've dislocated as frequently as Hemi. So I don't see any difference between them.
Of course, nowadays, there are a lot of issues coming in dual mobility, which is coming up. Probably, 5 years or 10 years down the line, we would know that what's the ultimate, verdict for the dual mobility. Especially in the United States, that people are finding a lot of intra-prosthetic dislocations and all those issues.
Dr. Shahid, sir.
I would add, 25 years ago when I came back from UK, we used to do Austin mode, and we used to revise a lot of them because of thigh pain and other problems. 2010 onward, I've been using cemented bipolar, and the revision rate has dropped down drastically. Some of my colleagues have been using total hip replacement, and we are reviewing the data of 15 years, and conversion of our cemented bipolar to total hip replacement is almost minimum. So, as said by Ross, that the elderly, fragile, fracture, the quality of life, look at the life expectancy, look at the data. In 1 year, 30% are not going to even survive, stay in the world. And even in the best surgery you've done. So my take home message is cemented femoral side stem, and I would not go for total hip replacement. And I would do a cemented bipolar. And in future, if you do a very good cemented stem side, if you have to convert to total hip replacement, it will be very easy. Save the stem and do the acetabular side.
So it would be a fair thing to say, as an answer to the question, that the jury is not yet out between how really the dual mobilities fare, and we would still know in another couple of years as to what the data has to tell us. But if you could do a 36 mm head, you would do a standard total hip, and in the very elderly non-ambulators or non-community ambulators, the choice of these procedure would be limited to the bipolar. So going forward on our program, we'll start with the debates first. And we have a debate on young hips, the choice, cemented total hip replacement in young hips. And we have Ross again talking to us on for the motion as to use of total hip arthroplasty in young patients, cemented hips for young patients. Ross, all yours. Ross, you're muted.
I would add one more point while Ross is sharing the screen.
Sure, sir.
In addition to the community ambulation, the cognitive impairment also, that factor has to be taken into consideration while deciding about the bipolar and total hip. Total hip has got a slightly higher dislocation rate compared to bipolar, but in terms of pain and function-wise, total hip outscores bipolar arthroplasty.
I would add my experience. I think in UK we went too much lean towards doing total hips, and the data is now coming that the elderly population, the bipolar cemented, is probably the best and safest operation you should be doing. To earn a total hip, you really have to be physically fit. In terms of the recent NGR data and the data from NHFD will now show that the mortality of total hip above 75, 80 years old is much higher than a standard hip. So you have to take this into account. So you have to be really convinced now. So where the trend went to doing 20% hip replacements in some units, the trend has come down to 10% now, which just tells you that everybody is experiencing the same issues. I personally don't favor dual mobility unless the patient has element of dementia, or you open the hip and the abductor deficiency is noted in some elderly population, which you can only see intraoperatively. Otherwise, we generally use 32 heads, which work for most of our patients, and they should work for it. But you have dual mobility on site in our hospital, so we can use it if we think we are dealing with a patient which needs it.
Great point.
Okay, is that sharing now?
Yes, absolutely.
Yes.
We can see a screen. Thanks.
Okay, so this is a debate about whether you should do a hip replacement in a young person. And to be honest, when I saw the subject, I thought, this is crazy. There's no argument. You do a hip replacement in a young patient, and I'm doing a hip replacement in a 14-year-old in a couple of weeks without any hesitation whatsoever. But reading the literature, it actually was quite interesting, and I'm going to give a more balanced view than I thought I would give about this subject. So I imagine the question mostly is arthrodesis versus total hip replacement in a, say, 18 to 30 to 40-year-old. Maybe there's a Girdleston's. I'll be interested to hear what the alternatives are, but I'm picturing arthrodesis versus total hip replacement. That comes down to availability, to cost, to what the intervention does to the rest of your body, to the results, and to the outcomes of revision. And I would contend that in the UK, and we've got faculty here to UK, Australia, US, Europe, everyone would do a THR. I don't think an arthrodesis would be an option in most developed countries. But in some countries, access to THR is difficult. And a simple arthrodesis is probably available in most countries. But as I said, I think in most developed countries, and this is not being patronizing or condescending, I realize that, access to healthcare is not universally equal. And the actual technique is not important, but what the conclusion of this study was that an arthrodesis is better than nothing. If you've got a patient with disabling hip arthritis and you don't have the option of doing a hip replacement, then arthrodesis is actually a very good operation. And I would support that as something that is entirely reasonable. Cost can be a consideration, but as we talked about earlier, in most of these markets where we have hip replacements, people use cementless stems and cups, and they don't care about cost. They could use a cheaper, better option, but they use the most expensive, less effective option. So, the difference between a plate and plaster and 18 months in a spica versus a hip replacement is probably not very different. And remember the probable future costs. If you do a hip fusion, the odds are the patient will need it taken down, and that will be a hip replacement. And the odds are they'll need a knee replacement, and that's a knee replacement. So the overall long-term cost to the patient is going to be much greater if you do an arthrodesis than a primary hip replacement. If we look at the perioperative risks, they're pretty similar. A fusion and a hip replacement have DVTs, bleeding, all the standard complications you'd expect. But a total hip replacement has few late extra-articular complications. So if you do a hip, then the patients get on with their life. You might need to revise their hip, but there's no downside to any other articulation. Whereas with arthrodesis, you're going to give them predictable spinal pathology, ipsilateral knee, contralateral hip arthritis, and massive abductor wasting that's going to make any future surgery and any hip replacement greatly compromised. What about results? The great thing about hip replacement is it works well in the young. This is our registry, and it's about a 12% 19-year revision rate in people less than 55. This is very different to knee replacement that doesn't do well in the young, but hip replacement is a great operation in young patients. And if we look at the Exodus series particularly, then you can see a 22-year survivorship of about 75% for all-cause revision and 97% survivorship for the stem. So good stems work well, or good hips work well in young patients. Look at the short-term outcomes of young people having arthrodesis. There was a high infection rate, only a 70% primary fusion rate, and a relatively high reoperation rate. So there are complications, but many of these were done for infection, tuberculosis, things we don't see in Australia. And I understand there may be some indications where it's a good operation. This study looked at 250 hips. Many had cast immobilization for up to 18 months, so it's a very long post-operative course. A highly variable union rate, lots of knee pain, lots of back pain, but only 9% were converted to THR. Not a great study. It's hard. There's very little to find, but a long, slow primary operation with a difficult recovery that has multiple long-term consequences. Revision. This surprised me. This is from the Australian Registry 2020, and you can see we'll take the 10-year re-revision rate of a revision at around 20%, which was higher than I thought it was going to be, and 15 years is around 25%. So not great numbers, and you don't want a revision when you're young. And these are the causes of revision, a lot of dislocation and a lot of infection, things that we don't really want to deal with. Here we've got a small series, but a 10-year survivorship of 74%, so a little bit lower than a revision of a primary to a total, but not greatly different. A very high complication rate, a very high infection rate, and a very high complication rate. This is 1,000 hips that were taken down and hip replacements done, and revision rate was 12% at 9 years, which is not that bad, to be honest. And the hip had been arthritis for around 30 years. Lots of infection, lots of instability, lots of abductor-related complications, but surprisingly good outcomes for revision. If someone does get a knee arthritis, you've got to do their hip, or they don't get any improvement in their pain, which means you're destining them to 2 operations, a knee replacement and a hip replacement. And again, 75% at 10 years, not as good as a total hip, revised to a total hip, but not too bad. So to be honest, the arthrodesis results are better than I had imagined. It's much more complex than a primary total hip replacement. It's not as good as a primary hip, and conversion is not as good as revision. To revise an arthrodesis hip is probably the hardest operation I've done in my life, and revising a cemented total hip is a breeze. And extra-articular complications are very common with arthrodesis. Thank you.
Thank you, Ross. And before we take any questions, I would like to ask Dr. Mohanty to speak to us on against the motion which is Total hip, cemented total hip arthroplasty for young hips. Dr. Mohanty, sir.
Okay, my slides are visible?
Yes, sir.
Okay.
Yes, sir.
Yes.
So, good afternoon, good evening, and good morning to you all. And I'm really grateful to Asia Pacific Hip Society, especially Professor Shahid, Noor, and Professor Abhay Elhence for giving me this opportunity. So, I'm going to move the motion in favor of uncemented total hip arthroplasty for young hips. It's an honor and pleasure to fight with Professor Ross Crawford, who is an world authority on cemented hips and a designer surgeon for the Exeter hips. I'll try my best to fight with him. So what is meant by young patient? WHO defines adolescents 10 to 19 years, youth 15 to 24 years, and young people covers the age range of 10 to 24 years. For while discussing about hip replacement surgery, for all practical purposes, we take that less than 50 years to be the young patients, because the demand from the hip is very high and we expect many revisions. So implant survivorship is measured by revision for aseptic loosening, and so hence the hip has to be superior in a young high demand patient, so that to reduce the less number of revisions in future. So as we know that in cemented hips, it's a cement bone mechanically interlocked. Cement intrudes into the cancellous bone, whereas on the cementless hips, it's a primary press fit stability which is achieved on the table, and later on secondary bone on-growth or ingrowth occurs, and what is known as a biological interlock. So what is more preferable here? The biological interlock or a mechanical interlock? Now, if it's a joint registry, these are, of course, 10 years back data in joint registry. The trend was towards uncemented fixation. Of course, now the trend is towards a hybrid fixation in most of the registry. They are the joint registry results in Australia, New Zealand, UK, and Sweden. And if you see Canada and US, the predominant use of uncemented total hip replacement, almost 95 to 99%, cases, the uncemented hip being used in almost all the cases. And of course, as I told you, that a trend is now towards the hybrid, because unfortunately the cemented cuffs didn't do well and didn't stand the test of time. And more and more people preferring uncemented cuffs. But on the femoral side, probably the cemented hip and uncemented hip, there is no comparison, and almost both are doing well. But there are certain advantages of uncemented cup, but that is because of modularity on the acetabulum. You have a choice of using the bearing surface, that you can use metal and polyethylene, you can use ceramic and poly, you can use ceramic. Of course, metal on metal has gone into disfavor now, and metal on metal there is a choice. So any kind of bearing surface you can use if you are using an uncemented acetabulum. Moreover, you have a choice to use a liner which is a neutral liner or an elevated liner to prevent a dislocation. You have a choice. You can use a dual mobility whip, which we are discussing just now a couple of minutes back. And you have a choice to use a constrained hip. There is an abductor deficiency. And you have a choice also to put a cemented polyethylene liner exchange if your cup is well fixed during a revision, so that the revision makes easier. One of the cases where, as you can see there, that there was a polyethylene wear, and the cup and stem are very well fixed, and hence we had to just do a polyethylene exchange, which used the elevated liner using a ceramic and polyethylene bearing. And there's a broad range of options for available in addition to the liner exchange. The post-operative instability, remember, that is the commonest cause of early revision in all the primary total hip replacements. So if you have a choice of changing the bearing surface, you have an option for changing the femoral head diameter to improve the functional outcome. For example, in a 48 size or 46 size cup. So if you are using metal and polyethylene or ceramic and polyethylene, the polyethylene thickness becomes much less and wear is much more. Hence, in those cases, you have a choice of using a ceramic and ceramic. So the head size, as it increases, your chances of dislocation, is less, and it provides better stability to the hip. This is one of our cases where a 32 size head has been used and patient is able to do the almost all the ground level activities, which is the need for our Asia Pacific patients. And we took the X-ray in those positions also, and it shows there is no impingement. So your technique is more important than putting those components in proper position so that there is no impingement. And if there is no impingement, there is no pain, and the patient is able to do more and more activities with a better bearing surface. Next comes the health economics. Prof told that the uncemented hips are expensive, but if you see the primary component, the cost is almost same. You take into account your pulse levers, you take into account the gun, syringe, centralizer, end cap, all these things together along with a cemented stem is almost equivalent to the cost of an uncemented stem. But the difference is on the SWR side. The uncemented cup is much more expensive compared to a cemented cup. But unfortunately, cemented cup, as I told you, has not stood the test of time, and the uncemented cup is now preferable all over the world. So future revision procedures may only involve exchange of articulating surfaces rather than revising the whole of the component. As you know, the burden of aging population, and in India now, in 2019, it was nearing 70, and of course, in 2022, life expectancy is more than 70 years. And it is much more in the developed countries like in Australia, in Canada, or United States. And the burden of aging population is increase in demand for total hip replacement. So increase in the absolute number of revision procedures in addition to that. So which is approximately much more expensive compared to primary. So do a revision which will be less expensive, just if the cup is well fixed, just exchange the liner. Now, the ease of component insertion, as David told that the ease of you can play around with a uncemented cup and a stem. So if you put your cup, and if you see during the trial reduction, your coplanar test of combined anteversion is not good, you can change your cup position, but until that is not possible on a cemented side. So your ability to reorient the position of the components, that flexibility remains on the table, which is much more easier for the young orthopedic surgeons. And that is why probably most and more young orthopedic surgeons are preferring cementless implants for ease of insertion. Cemented hips, definitely it requires a lot of experience, and you have to be matured enough to handle the cement in the operating table. Now, if you see the patient satisfaction outcome, the hard and hard bearing surfaces, the patient satisfaction outcome is much better, and you can provide a hard and hard bearing only with the cementless implant. And we had published this paper a couple of years back that the patient satisfaction outcome is much, much better. That is the forgotten hip, whatever you tell, is with a ceramic and ceramic type of hip. Moreover, in special situations, for example, a patient with a fracture with a stiff hip with a avascular necrosis. So here the choice is only remains as to a uncemented hip in a post-traumatic situation, or do a type Crawford, dysplastic hip where you do a reduction osteotomy or subtrochanteric osteotomy. There, probably uncemented stem will provide a better fixation compared to a cemented stem. And of course, more of a periprosthetic fracture. As you tell that the chances of periprosthetic fracture is much less with a cemented hip, but after a periprosthetic fracture happens, then when you are revising a periprosthetic fracture, then you are doing wiring and putting an uncemented stem in much better situation compared to a cemented stem there. We had done a study about a couple of years back, and we studied in young patients less than 35 years. And in less than 35-year young people, we have used almost cementless implant 92.5% in my series, and cemented in 7.5%. And most of them were on ceramic more than 70% of these cases. And this is a comparison to the world literature of young patients less than 35 years. And in my study, this was we had done 110 patients, 160 hips, and most of them were only avascular necrosis, around 50% or avascular necrosis. And there is excellent outcome with no revision yet. So this is on an average about more than 8 years follow-up of this patient. This is one of the patient who has got 14 years follow-up after multiple surgeries doing a cemented hip on both uncemented hip on the acetabular side as well as on the femoral side with a trochanteric wiring. So to conclude, young arthritic hips, uncemented is a preferable option. Uncemented cuff has a better performance. It offers modularity. Technically, it is easier to handle uncemented cuff and uncemented stem, and there is an ease of revision during revision procedures. And I told you it's cost effective to on the comparing to the cemented hips that if you consider the future revisions, and it offers better satisfaction in hard bearing surfaces. And I told you in special situation, post-traumatic dysplastic, Crawford, or in case of revising a periprosthetic fracture, probably uncemented stems are preferable compared to a cemented stems. I thank you for a patient hearing.
Thank you so much, sir. Brilliant talks both. And before I can go to some questions, which I can say, can I just ask both Dr. Ross and Dr. Mohanty, if you can just quickly enumerate for the benefit of the viewers and the audience, what in your book is the reason to do a cemented total hip in a 25-year-old and in a 50-year-old? And the same I would request Dr. Mohanty to do. Why would you do a cemented total hip in a 25-year-old, and would you do anything different at 50? And Dr. Mohanty, why would you do an uncemented hip in a 25-year-old, and would you do anything different at 50? Ross.
Okay. Firstly, excuse the confusion. The topic was total hip in the young. I didn't have anything about fixation, so I thought it was total hip versus alternative. So I didn't defend.
Not a problem. That's fine.
Look, if you put a cementless stem in a young person and it on-grows, it's almost impossible to revise. They get proximal stress shielding. They get massive loss of bone in the proximal femur. The next revision is a nightmare. If you do a cemented stem with a polished tapered stem, it loads the femur in compression. A cemented cement revision takes 10 minutes. It's the easiest operation you'll do in your life. And this is a debate, so we can be nasty, but that question that it's easier to revise an uncemented stem is rubbish. It's the hardest revision you'll do in your life. A well-fixed, on-grown, uncemented stem is an ETO, is a long stem. It's life-changing. It's disabling. A cemented cement revision of a cemented stem is a breeze. There's no cementless stem that beyond 10 years doesn't have massive proximal stress shielding and osteolysis. The bone just vanishes. It's a death sentence for a 25-year-old to put an uncemented stem in them. It's just not what you should do.
And would you do anything different at 50? And would your choices,
every single patient,
would there be a reason to change?
Every single patient in my career has had a cemented polished tapered stem.
Okay, Dr. Mohanty.
Yeah, in either 25 or 50, I would go for a uncemented stems. The only thing I won't do a uncemented stem with the bone quality is poor, like a type C canal in any of these age groups as well. The thing is that, earlier generation of uncemented stems had not done well, but then now we have published result of coral stem, for example. There are more than 30 years results. We have a bicontact stems. There are a couple of uncemented stems which have shown very good long-term outcome. I would agree with Prof that if the cement is well fixed, okay, you do a cement and cement, but those are in certain number of cases. In every case, it's not possible to do a cement and cement. If the cement is well fixed and your canal has to be, really good, and you should get a good, cement and prosthesis should be going inside your cement and cement. But in each and every case, you cannot do a cement and cement. You have to do a ETO to take out the cement, or you have to take out the cement through the canal with using all Moreland instruments or all these instruments, and then you have to depend on the distal fixation. And while you put on you depend on distal fixation, putting another cemented stem, long stem, would be disaster for the canal. You are just replacing and more bone with with a mechanical substitute. So
Yeah, look,
it's
a lot of that's made up. The Karai stem now has a collar because the results were rubbish. The results of there's no good long-term data on the Karai. You can say that, but show it to me. Show me the data. And then to take a well-fixed Karai out, you need to do an ETO. And there's no bone in the proximal femur.
I would agree. You have to do
terrible operation. So you can't say what you're saying. That's not true. The Karai does not have. I showed you in my earlier talks. It's twice as bad as an Exeter at 15 years. It's not. And everyone says Karai pinnacle, but why have they put a collar on it? Why do they keep changing it? Why do they keep changing the coating?
That's a different issue, Prof.
It's not. You can't talk about 30-year results of something that didn't exist 30 years ago.
You can't get around Prof. Ross Crawford. But for the benefit of the audience, we would still like to, enumerate what would be the choices of doing an uncemented hip for a young patient. Obviously, Prof is very dogmatic and he's correct when there is data. But still, the world is performing uncemented total hip arthroplasty for the young. And what would be the 1, 2, 3, 4 choices in your book, Dr. Mohanty, sir?
Why the world is moving toward, younger surgeons would prefer to do uncemented. Are they influenced by the manufacturer or the company people, or it is the age of surgery, or anything else? What Dr. Ranawat tells and what we follow in life, that everything good that will prevail and it will not go out. So if most of us, we feel that in our practice, if uncemented stem is doing well, there is ease of surgery, then it has to sustain the test of time. It's literature shows that in Prof's literature, Prof is an excellent surgeon. He does very good cementing. Even writing down results are often very good. But thing is, it has to be the thing which works in an average orthopedic surgeon will stand the test of time. It's not that every surgeon is excellent and everybody can perform an excellent surgery, but one has to learn. Of course, there's a big learning curve. And yesterday, actually, I'm in the Pune knee course, and yesterday we are discussing all our overseas faculty here that whether the surgeons are getting influenced by the manufacturers. Everybody told, yes, it is true, it is correct. All over the world, the surgeons get influenced with the manufacturers. That is the trend which is going on. Probably, few surgeons like Prof. Ross Crawford, Chitranawat, all the many surgeons, John Insall, they might not be influenced, but everywhere the centers are, they're influenced by the manufacturers as well. So all these trends, it's a true hard fact. One has to digest that. So the age of surgery, doing the surgery, influence of the manufacturers, and a good quality of bone and a good, quality of implants, that leads to doing a uncemented hip, and more people are following it.
Thank you so much, sir. And that actually leads me to another question, which is the point which you're both trying to drive at is, there's a question which says, how important is supervised training to be able to perform a cemented total hip arthroplasty today? And if one feels the quality of training is not adequate, then should uncemented total hip arthroplasty should be the way to go. So can I start with Dr. Fatih? What's your take on this question? And a quick answer, sir.
So yes, the cemented arthroplasty needs a special care in surgical technique, and because of the fourth generation cementing and the canal preparation, all this stuff needs some important steps that has to be taken care of. So therefore, which is not required in uncemented prosthesis. So it's much easier for in terms of education or the availability of other setting in the OR. Sometimes it's not accessible, and the fourth generation cementing is very important in the outcome and the longevity of the prosthesis. So therefore, yes, in terms of education, I think it's important to dedicate a special.
So the question is that if you have the right training for a cemented total hip arthroplasty, you do a cemented hip. If not, then should surgeons be doing an uncemented hip?
Yes.
Okay. Dr. Shahzad, a quick comment from you. You're muted probably, Dr. Shahzad.
While he's waiting to reply, can I just say,
yes,
I personally would not pay a large sum of money to go to a concert hall with a wonderful atmosphere, wonderful hall, and listen to an untrained pianist. Nor would I pay to have a hip replacement by an untrained so-called specialist.
So training is important for both either cemented
Obviously,
or uncemented
Only
hips.
that, but trained and talented. If you're no good at it, please just don't do it. If you can't do it, don't do it.
Right. So the question is a little bit finer than that. And it's basically asking that due to the paucity of cemented hip trainers, if one is not able to reach a proper cemented hip trainer, then should having been exposed to good uncemented hip training and good uncemented hip total hip arthroplasty, should one resort to one way or the other?
More and more hip surgeons are being born every day and being created every day. There will be competition. You will die if you can't do the job.
Okay, so we're talking to two hardcore cemented hip surgeons. Ross, what's your take on that?
This is an embarrassing conversation. We know the data, and if I was on an international faculty and I said I wasn't good enough to do a cemented total hip replacement, I would retire. If you can't do a hip replacement, you can't tie your shoelaces. It's really easy. And I want to share a quick picture with you. Which one's easier? This one is hard. The cementless stem, it's hard to get right. Sure, it's easy. Any idiot can bang a cementless stem into a femur, but they get crap results. That is embarrassing. If you can accept a double revision rate within a week, then really that's not the right thing by your patients. If you can say, I don't know how to do a cemented total hip replacement, and you're an arthroplasty surgeon, that is so embarrassing. So that you know the data, you know the results, and you don't want to learn. And I can't believe the faculty would support the position that, oh, it's too hard. I know the results are really good, but I can't do it. So that is really wrong.
To voice the message from the two diehard, giant and experienced cemented hip surgeons is that a young surgeon should go to any length to train to do and learn a cemented total hip arthroplasty. But I think Dr. Fatih, Dr. Mohanty sir are of the opinion that yes, uncemented arthroplasty is an option, especially if you cannot reach a very, very good trainer. Would that be safe to say? Dr. Shahzad, one quick opinion.
My quick opinion is that the evidence is saying that 90% results are good for both uncemented and cemented. You have to look at on your practice what you are good at. And in your hands, if you are doing 80% uncemented hips, then obviously you will be good at uncemented hips. My own practice is that I find it easy to do a cemented hip and adjustment I can do with Exeter stem or a polished taper stem than an uncemented stem. I have never taken uncemented on the table out, but I just feel that I feel more comfortable because my practice is to do 60-70% cemented stems. So evidence is 90% good results for both. Now, if you look at on your practice, you want to be 95% less revision rate for infection or intraoperative fractures or early complication, unpredictability of the bone. You can go for 90%, then you probably will choose Exeter stem or polished taper cemented stem. But if you are happy that you're going to do 90% good result, which is pretty good result. So the world is going in terms of uncemented stem and has gone. The trend is difficult to reverse. In our own hospital, I work in 5 hospitals, and I don't think it's just the surgical training. The cement is dependent on training of the staff around you. So it is the nurse giving you. So if you are working in a hospital where 80% are uncemented, a lot of staff is not trained to do a good cemented hip. And so that is the reason the trends have changed. And I totally agree with Ross. The trends are changing, not looking at the data, the trends are changing. What is more convenient, and overall results are 90% for both. And that has changed the trends. For the implant companies, uncemented market is the way to go further. There is nothing new in cemented polished taper stem, which is being used for 40 years.
Thank you, Dr. Shah. That was a brilliant summation. Dr. Shahid, sir, you have something to say.
I think as a leader of arthroplasty societies around the world, I feel the responsibility lies in our hand. We've not been able to provide hands-on training to young surgeons. So surgeons resident in USA, they're not exposed to cementing technique at all. But the irony is that in India and Pakistan, people are moving toward uncemented. So the conclusion is that it is our responsibility that we provide more training opportunities as AO Synthes provides in their fracture fixation. So if we are as a society provide more opportunity, then this trend is going to go forward. And this is talking about primary total hip replacement. What about revision total hip replacement? Impaction grafting. How many surgeons are trained to do impaction bone grafting of the femur or in the acetabulum? So cost might not be an issue in Australia and New Zealand, but cost is an issue in Malaysia, India, Pakistan, and Bangladesh. So this impaction bone grafting is a dying skill. And then we don't get the appropriate cages for the proximal femur and for the acetabulum and technique to resolve. Look at the data. The data is very good for impaction bone grafting, both for the acetabular and femoral side revision. That's my...
Provided it's properly done under proper training.
That is exactly what I'm saying, that it is our responsibility that the senior surgeon who've been exposed to these techniques, we have not been able to promote and provide mass scale training. That is our fault.
Very
conclusive words, if I can. Sorry. So I didn't want to say that if a surgeon does not have enough education and a cemented technique, then it's a way to go for the uncemented. That doesn't mean that the cemented technique is not good, but if one does not have that education, there is nothing to do with it. And unfortunately, nowadays, in the Western world, especially in the Western world, the uncemented the prosthesis is propagated, and it's more and more like advertised. Therefore, unfortunately, as Dr. Noor mentioned, unfortunately, the impaction bone grafting or cemented technique is not very well known in young surgeons. That's not good. I think the cemented technique should be a part of formal education, which is a part of our course that I'm going to mention. As Dr. Noor knows, we have a arthroplasty course in Istanbul, and it's a part of that course is just dedicated for the cemented arthroplasty, just to make it clear for everybody.
But can I put in and say something here? I tell you, everybody goes on about technique and learning technique. I'm not the greatest hip surgeon around. And certainly when I began, I'm definitely not the best. And I had the worst cases to treat. And cement bailed me out every time. Use a polished taper stem. You do not have to have a complete cement mantle. It will not fail. I've done terrible revisions with no bone stock, using barely any cement to cover the gaps. And those implants have survived. And you would never be able to do that with a cementless implant.
Ross, can I ask you a question?
Very quickly.
Very quickly with David's comment. So we've been reading about cementing technique, first, second, third, and fourth generation cementing technique. And what David is saying is that he has got away with poor cementing technique. So how valid is cementing technique in improving the implant survival?
Not at all. Not at all. Robin Ling didn't use a plug, put it in by hand, use the thumb. You can cement super bad and you get good results. It's not that hard.
But you got to use a polystapled stem.
Yes. Yeah.
Okay, going forward.
Just of note, the biggest growth market in the US in hip replacement is cemented total hip replacement. They've worked out that they need to cement their hips, and they're growing at 5% year on year. And you guys are
by the way, the same company that sells you the uncemented stem also sells you the cemented stem.
Okay, so going forward on this one, the B2. So we have another debate. Unfortunately, one of our speakers is not able.
Abhay. Sorry, yeah. I really need to get this on in. You'll love this.
Yeah.
You know the difference between young people and old people? They have more sex. If they've got painful hips, they can't bloody have sex. If they have stiff hips, they can't bloody have sex. So give them some pleasure for 20 years, then revise a hip. Who cares?
Fair enough. Thank you, David. So our next speaker is Dr. Fatih, and he will talk to us on the uncemented side as to how to deal with the periprosthetic fractures, especially the B2 and the B3 ones. So unfortunately, we do not have Nikhil, and he's had to bow out because of certain emergent issues. So we'll have Dr. Fatih speaking to us about the uncemented total hip arthroplasty for periprosthetic fractures.
So thank you for giving this opportunity to me. I'm going to talk about as you mentioned, the uncemented femoral component used for periprosthetic fractures. But as I use I cannot just. I'm assigned to make this talk in favor of uncemented technique, but as a scientist, I cannot just favor just one of them. I try to summarize the literature, and some situations may require to make an uncemented, but in some situations the cemented is better. So I try to clarify this issue during my talk. Unfortunately, this is a short talk, and my partner is not here, but I'm trying to do my best. So it's the periprosthetic joint fracture, periprosthetic fractures.
Excuse me, can you make it full screen? Can you put a slide show? Click on the right lower corner.
I'm sorry, I couldn't get. Oh yes, sorry. Maybe this is Thanks. So the periprosthetic fractures are very challenging complications, and the mortality rate is really high after these complications. And we have to know that the periprosthetic fracture is a pathological fracture. It may the component stability is important here, and also the bone stock is important. It may be the fracture may be because of the previous loosening of the implant, or it may lose after the fracture. So these two situations may have to be differentiated from each other, especially if there's a low energy trauma and a broken bone after a usual daily activity, or any previous complaint about the prosthetic joint, that has to be taken into account. Unfortunately, the literature in this topic is very limited, and the numbers of the cohorts are not so much. So when we look at the literature, the Vancouver classification is really leading not only to classify it in a radiological manner, but also it leads us to find the best treatment methods. And for that, according to this classification, we have to make a good assessment preoperatively. And as the type of the fracture, according to the Vancouver, is important, we have to make an accurate radiological assessment before the surgery. And if that the assessment cannot be done in an appropriate way, the selection of the treatment implant or the method will not be adequate, so that would be subsequent problems. So let's look at the problem in the way around this. So let's think why the periprosthetic fracture treatment failed. So when we look at the literature, we see that if the stability of the implant is not well, if the classification is not assessed, characterized well, and if the selection of the treatment is not well in terms of the implant and the technique, then it will fail. One of the studies about that shows that the type of the fracture, implant stability, and the bone loss, these are most important three factors that directly affects the outcome. So according to that study, the etiologies of the refracture of the periprosthetic fracture is mainly two etiologies: the infection and malunion. The infection is a problem for every revision. But malunion needs a special consideration here, and that's mostly because of inadequate stability of the implant and the viability of the tissue. So the causes of the failure, when we look at the causes of the failure, at the end of the review of many studies, we see that the implant used did have important influence in the success. And according to that, the uncemented, extensively porous coated implants seems better in periprosthetic fracture, but it has to be extensively porous coated because the proximally coated ones does not do well. But the cemented long stem implants, if it's done with especially the impaction bone grafting, they also do well. So, but when we look at the general application, the trend, as I mentioned before, unfortunately, the only uncemented stems are more commonly used because something is missing in our education in this, as also Dr. Noor mentioned. Sometimes, especially the bone loss, if the bone loss is, or poor bone stock is there, the long cemented stem with impaction bone grafting works very good. When we look at the uncemented revisions, the straight stems, Wagner type tapered stems with a diaphyseal fixation, which bypasses the fracture line at least like 2 times of the cortex diameter, they also work well. Also, for those patients who does not have well bone stock, impaction bone grafting also can be applied with uncemented revision situation implants. When we compare these uncemented and cemented revisions, unfortunately, the papers on this is very limited. The Springer et al. Made a comparative study about that, and their primary endpoint for this study was removal or revision of the femoral component for any reason. Among the 118 hips, they revised 22 stems. At the end of that study, they have a conclusion of the most important problem in long term is prosthetic loosening and fracture non-union. And the better results has been achieved with uncemented and extensively porous-coated stems, because in cemented revisions, the non-union, knee fracture, or residual bone defects are seen more, but we have to look at it more carefully, because Sridis, who's doing very commonly this impaction bone grafting and cemented technique, in their study, they find that the long stem with impaction bone grafting do 4 times better than long stem without impaction bone grafting in terms of fracture union. So the problem of the fracture non-union in cemented prosthesis may have a technical detail that the surgeon has to be taken into account. I mean, the impaction bone grafting has very important role in here in union. Also, the stem size is important. If the long stem is used with impaction bone grafting, it makes a 5 times better outcome compared to short stem with impaction bone grafting. So the cemented prosthesis also works well, but the technical detail, the technique here is very important. The cemented revision do well with impaction bone grafting, especially the large metaphyseal bone defects or the very large the canal is seen in the patient. There are some potential disadvantages as well. The impaired union due to the cement penetration. So this is a technically important thing for a surgeon to be taken into account. And also there's increased risk of some osteolytic areas or the cement mantle defects. These are important for this technique. And if it's not done appropriately, the early component subsidence may be seen in these patients. Also, the technique in impaction bone grafting and cementing is important because as we saw, the most common failure of the periprosthetic fracture treatment was the non-union was non-union. So the stability of the initial stability of the implantation is important. And this technique is very operator dependent. So the cycles and the energy that's applied for impaction is important, and the fracture should not be propagated. And the impaction bone grafting needs some special instruments, which is not available or accessible for some or maybe mostly in some institutions. So as a summary, I can say this study is a good one. So when we are talking about the B2 and B3 types of periprosthetic femoral fractures, for the B2 type, the cemented or uncemented stems can be used. They have both comparable results. But when we're talking about the B3, then the cemented stems might do better because of the bone stock restoration is possible with impaction bone grafting. As a result, the periprosthetic joint fractures, periprosthetic fractures have high mortality and morbidity rates. The Vancouver classification is important not only for radiological classifications, but also for treatment. decision, and therefore the very careful assessment is important, and also the patient history is important, whether that was complete before the fracture or not. And based on these, the stability of the implant, as the stability is very important. The technique that's selected has an important influence in the outcome. So by passing the cortical defects, at least 2 cortical diameters, and restoration of the bone stock is important with impaction bone grafting. Thank you for giving this opportunity, but I would like to mention about our course that's going to be done by the end of this month, August, in Istanbul. Thank you.
Thank you so much, Dr. Fatih. That was an absolutely brilliant discourse on what to do, and actually it serves our purpose better, especially because we don't have one of our speakers. But just to take you all away, I have a question which actually asks us exactly that. So a very quick question and from all of you. How do you clinically differentiate between a B1, B2, and B3 on the table? And what is your guide to making that call on the table? So can I start with Dr. Shahzad, sir? Very quick answer, please. How do you differentiate clinically between what is a B1, B2, and a B3? And is there any evidence? That's what the question says.
You have to unmute. Dr. Sajid, you have to unmute.
Shahzad, you have to unmute, please.
Yeah.
The current practice is to assess the fracture with X-rays and the CT scans. And those two provide you some information, whether the stems are loose. Having said that, you have to take into, I always believe, once you're going to take cement out, or you're taking an uncemented stem out, you're going to change the scenarios. So there will be intraoperative problems. So the definitions do change from
so how do you,
one fracture.
The question from
for me, a loose stem is, which is easy to revise, that is the loose stem. In our practice, or we are seeing still most fractures coming in cemented stems, which have been done some years ago. Over the years, again, we tended to replace them and tended to replace if there is a doubt, if the stem is loose or the cement mantle is bad. Having said that, a lot of evidence is coming that with Exeter cemented stems, even if the loose stems, you could try to fix the fractures. So the pendulum is shifting towards fixing, especially if you are dealing with an Exeter stem. And this is exactly the experience we are seeing. So I would say for me, it is assessment on X-rays, CT, and then intraoperative judgment of the surgeon. I don't go with a fixed mind. My final decision is right when I'm dealing with the patient and I have dealt with the situation.
You have to unmute.
Over to the other colleagues. Any other tips?
Abhay, you have to unmute yourself.
Yeah, Rose, can I quickly come to you? How do you take that call, make that call on the table, whether my patient on the table is a B1, B2, or a B3? So you make a preoperative radiological diagnosis, but then what makes you decide this is a B1 or a good stable stem or an unstable loose stem? Obviously, the bone stock not being there B3 is not too much of a problem.
No, so we published on this. We're the first to publish on this a number of years ago to basically say it doesn't matter. It will become a B2 on the table. They're not stable, but it depends what they started as. So a well-fixed Exeter stem that has a fracture, you can treat it with cement or with a plate or with you have to revise the stem, but to me, it's whether they were loose before you revised it or before they fractured or after they fractured. They're all loose after they fracture. It's that pre-fracture. So we look at whether they were, the radiology is irrelevant. They're all loose. If they've subsided and fractured, then you have to revise it.
Then what would be a B1 in your book? Would you fix any of them?
No.
If they were all loose?
They're all well fixed before they fracture, but they become loose.
That means B1 is a non-entity. You would not fix any of these stems which fracture, even if by radiology they were B1.
If you think about a periprosthetic fracture of a cemented stem, if they fall and break it, it's not where it started.
Sure. So B1 is a myth in your book.
Yeah, I think it doesn't exist.
Would that also mean that no periprosthetics should be fixed? They should all be revised?
In my hands, yes.
Okay. Would David, do you believe in the same philosophy?
I agree with Ross. I mean, we've had implants that on the face of it, it's just distal to the cement mantle and it shouldn't come loose, and they've come loose over time. Dr.
Mohanty, sir, your take on this?
Yeah, if the cement mantle is not broken, then it's I would fix it. But if the cement mantle is broken, actually B1 is a myth. If the cement mantle is broken and you tell that the prosthesis is stable, then that requires a revision.
Okay.
But what Prof told that ultimately it is going to loosen out. Better to revise it.
So there is some change. Some change in the quality.
Femur?
Yeah.
Sorry, how can you break the femur and not the cement mantle? It's impossible.
No. What I'm telling you is cement mantle is not broken. Only fractured femur is there. Then that is the only indication of fixation. So that mostly it goes towards the type 3. Type C. But if the cement mantle is intact and most of the femur is not femur is broken, then one can fix it.
I think the difference in ideology, which Dr. Mohanty and Dr. Ross are pointing out, is that Dr. Ross says that if you fractured the femur, the interlock is broken. So you definitely B1 is a myth, and that is why he will not fix, he will revise. And David conforms to that. And Dr. Mohanty says that even if you fractured the femur, if the cement mantle is more or less okay, then you can still plate the femur or fix the femur and retain the prosthesis in its place. Is that what you're saying, sir? Yeah. Okay. Dr. Fatih, would you differ? So clinically, can you differentiate, or is there a need to differentiate between a B1, B2, or a B3, or is this classification redundant?
So it's very difficult to assess if the cement mantle is intact or not intraoperatively. And as mentioned, if there is a fracture at the level of the implant with a cemented one, we assume that the cement mantle is also damaged. So we accept the B2, B3 differentiation is not very valid in terms of especially selecting the type of the fixation and the surgery.
So in your book, would you ever plate any femur or fix a periprosthetic fracture? Or would you revise them all?
Yes, for all B yes, we make for the B type fractures, we revise it.
So in your book, there is no place for a B1, and you would revise all the fractures which are in and around the cement mantle.
Yes.
You would consider them all B2.
Correct.
Dr. Shahzad.
This is not my experience, and the data has come from Edinburgh and from Exeter that the well-fixed good cement mantle and Exeter stem does behave equally well with fixation. So I don't have very extreme view that I would not fix any fractures, because you're dealing with the patient. So you have to take into account the magnitude of surgery, revision surgery, adding dislocation. So all these factors will come into play. But as I say, in my practice, I started with that view that every stem is loose until proven otherwise. But I have changed. And because in my practice, majority of the patients have got cemented stems, I still fix. I'm fixing probably more in the last 4 years than what I revised 5 years ago. And that is evidence-based.
So is there a guide to which stem you are going to fix and which one you're going to replace?
I mean, if it will be patient dependent, like any surgery in orthopedics. We are discussing that bipolars are doing well in some elderly if you have the same population, how you start revising? If you just look at the hip fractures. So the way I see it, the periprosthetic fracture is the next hip fracture. It's the same population. The same principle will apply how you deal with the hip fractures. So when you have a patient, 95-year-old, is he going to tolerate a revision surgery? Then you add dislocation, then you have 3 hours. So if you are dealing with fracture, which are fixable, and the magnitude of surgery is proportional to the patient can tolerate, you would add towards fixing it. So I have shifted the pendulum from revision to fixation in cemented options, and wherever I feel, I will get away with fixation. And fixation has improved. What has improved is, in fixation, what we learned is that we should use longer plates. We should have a rigid fixation. And because the more modern plates and the better cable system and fixation has also improved what 10 years was available. And that's why the results of fixation are much as equivalent as revision surgery if you look at the overall morbidity, mortality.
Dr. Shahzad, sir, your practice?
Hello.
Yeah, your practice, Dr. Shahid, sir?
Sorry. I agree that it is very difficult preoperatively to check between B2 and B3, and my preference has been to revise. And I've been using uncemented diaphyseal fixation, fluted stem, and using extended trochanteric osteotomy to clearly remove my implant and do bone grafting. And I've had very good result. Obviously, in type C, I do fixation, but type B, my preference is revision.
Okay, so just as a guide, I think the Vancouver classification does not give us an actual guide as to whether the stem is loose or not, even though it is classified very well. But I think there is a Tower and Beals classification which does tell us that if the fracture involves about 2/3 of the stem or the cement mantle, then the prosthesis is assumed loose. If there is subsidence of the stem, then it's probably, as Ross said, was the stem loose before or after the fracture? And if you've seen something like a pedestal sign, then obviously the stem is loose. So some guides for the audience as to what they are dealing with. So going further on this, can I invite our next speaker? And I'm very grateful to David that he's chosen to talk to us on the revision hip. So would you like to come first, David, and speak for the motion for revising a Paprosky 3-4 femur?
Actually, my talk was the other one, revision for cemented revision for any, but it'll include Paprosky 4 for sure. Because I'm going to just show you my villains list. And this is a talk I used to give, and I still give occasionally. And this is my own practice. So this is a lady here who came to see me with intense pain, and she'd been treated multiple times by her own surgeons over the years, and just told to bear with it. And this implant is obviously loose and needed revision. And you can see here that there's an impending, in fact, there is a periprosthetic fracture, and we've just revised it this way with impaction grafting. And those days, those oblong cups were available, and they seem to be still surviving in this particular patient although they've somewhat acquired a bad reputation over the years. And just to show you what happens with these, the big plates of bone, we've written about this, they're laid onto bone. You'd imagine that you devascularize the whole proximal femur. This is October 2001. And 3 years later, you can see there's total incorporation of everything. And she's doing okay, such that she was walking up and down stairs when I saw her. Here's an old lady with an osporitic periprosthetic fracture. Clearly a lot of loosening there anyway to begin with. So what did we do? There were 3 bits. And we just removed the implants, put a long plate on it, on the side plate, attached some screws, distracted it. We actually went submuscular to try and avoid damage to the musculature on the lateral side. Then we just reduced the fragments, put some circlage wires across, and inserted a long stem. And she did reasonably well and was walked home about 5 days later. And because it's cemented, she could do that. So here's a patient. That's the right side. You can see that there's a periprosthetic fracture or an impending fracture, at least on that very loose stem and cup. And just to make things worse, that was what he actually presented with. That's the left side. So we went ahead and we just, tried to treat the left side first by simply letting the fracture heal up. Because we worried he had an infection there. And when everything cleared out, we actually revised both sides. And you can see, I'm just telling you, there's barely any cement there. That's 2005. Look, there's no cement there. And look, that hole there was so big, we just tossed a bit of metal in it, the mesh, and then we put some cement to follow, barely any bone graft. And this was him a year later. The video, I don't know, maybe I can make it play. I can't. He was, he was a case of ankylosing spondylitis, a taxi driver. He could walk and stand and sit and drive his taxi. He was happy enough. And finally, he succumbed 3 years ago. So he had 14 years on the hip. And what actually killed him was his tuberculosis, which had spread throughout his body. So here's another case. This implant is totally loose. He comes from up north. You can see that he's got a massive periprosthetic fracture. And what we did was just to treat it with impaction grafting. I don't know if the video, it won't work. But anyway, that's the final result. That's just impaction grafted. And we sent him home after 10 days on the ward. He went up north. We didn't see him for a year. We actually called him back to see us after having located him with some effort. And here's his story. He stayed in the hospital for 3 weeks. He was involved in a road traffic accident 5 months after the surgery. His bicycle was knocked over by a car. He fell on the road and nothing happened. He was fine. And that's his x-ray. You can see there's a lot of bone incorporation, and he did well up to that point anyway. It was so hard to find that I don't think we ever saw him again, but you can see that there was a lot of bone regeneration. There's barely any bone in the proximal femur there, and we've actually reconstituted it all for him with impaction graft. And infection, this loosening and periprosthetic infection after multiple surgeries. We put a big porcelain in there sort of thing, and then we put an allo implant in, and here she is 2 months after that. Happy enough, infection-free. Here's a lady with 80-year-old lady with 80-year-old lady with 8 years of discharging sinus and mouth. Everything's loose. There's at least a trochanteric fracture, and just gone and revised it with lots and lots of antibiotic cement. And you can see here, there's lots of metal thrown in. Single stage revision. This was a single stage revision. Here she is a year after, and she's actually doing well. I'm sorry, the video doesn't work here. Okay, so single stage revision for these cases is nothing new. It's been around since Wroblewski's time. He wrote about it in 1986. Okay, and it works. Siny and Rock wrote about it as well. Same thing here, young man with infected hip. And they treated, this was after 6 weeks of antibiotics, and he could go up and downstairs. So I would say that actually it really does work. Cement is exceedingly forgiving. Am I still sharing, or have I stopped sharing? I think I've stopped sharing, right?
Yeah, you stopped sharing.
Okay, so I would say that, you know, cement doesn't have to be complete for you to get great results.
Okay, so may I quickly invite our next speaker before we go on to the discussion, Dr. Shahzad, your talk on against cemented total hip arthroplasty for Paprosky 3-4 Fema.
Abhay, it is actually for Shahzad Sadiq.
Yeah, sorry, for cementing a total hip arthroplasty.
Are you able to see the screen or not yet?
No,
not yet.
Okay, let me just work it out. If somebody wants to talk in the meantime, I think we carry on the discussion.
Abhay, can we have few questions while Shahzad is trying to sort out his screen share?
Yeah, so can I just start on with a case for the panel if we are to take some questions? Or maybe if Dr. Shahzad is...
Yeah, it will not be possible because he's sharing this screen. And we can take...
Okay, so I'll just go on and check. So
are you able to see any of the screen now?
No, not at all.
No, not at all. Not at all.
What about now?
No, we can't see a screen.
So I'm looking at this. How about now?
Yes.
You can see your presentation now. You can start.
Okay, so discussion today is how to manage the bone loss, and you did confuse me that am I speaking against or for it? But
you are actually.
The discussions, if you look at the, you have to look at the evidence, to be honest, and you have to go obviously with your own experience over the years you develop. And your training, but I think there is a truth in bit of both. The question is, there is no doubt we will be dealing with a lot of this problem, femoral bone loss, because we are doing a lot more joint replacements, and the number of implants are increasing. Just need to see whether I can get the control. So we're not going to go too much into the details, but just briefly going to the Paprosky's classification. In type 1 and in type 2, we are basically dealing with bone loss, which is proximal and close to the metaphysis, which is quite often seen in patients who presents with primary hip replacements, which has worked loose over a period of 10, 15 years, whether it is uncemented, where the socket wear is damaging the proximal bone, or some other issues. And 3 and 4, we tend to see more dealing with second and third revisions or with fracture situations, which will be the more complex problem. And we are dealing with bone loss, which is extending towards the shaft of the femur. I looked through the same slides, and if you look at Paprosky's paper, he talks about type 1, use cementless hip fixation, S-ROM, extensive porous coating. For type 2, cementless hip fixation, extensive porous coated stem, uncemented. For type 3A, uncemented. For type 3B, and pretty much uncemented. But he mentions could be used cementation and impaction bone grafting. So in his book, when he wrote this classification or his clinical experience, the cemented Rivian didn't exist. But we listened to a wonderful talk from David Choon and his experience, and he's dealt with a lot of these complex problems using a cemented stem. And I think if you're an experienced surgeon, you know how to use cement well, you know how to do impaction grafting, you will use your expertise to deal with the problem, what you are good at. So my question is, what is causing this bone loss? Are surgeons responsible for this bone loss? What role we have to play? And then you go back to Ross talk. Yes, we are responsible because we are picking the implants. We are deciding whether I'm doing an uncemented hip or a cemented hip and what type of cemented hip. To some extent, the future surgeons will be facing this problem depending on what their peers did 10 years ago. Osteolysis is likely to persist. Infection is likely to persist. And intraoperative problems during surgical techniques will likely to persist. The patient factors will play a role. And the main thing is a lot of population going orthopedic surgery is older population, osteoporosis, trauma, fractures, prone to partly osteoporosis and partly post-traumatic. So what can be done to prevent bone loss? Again, BO has a special committee on Get It Right First Time, and the talk is about to use the right implant the first time, rightly done, right place, prevent infection, dislocation, and selection of implants. And we alluded a little bit to the Charnley hips. And this is the slide from his own book. So in his hand in 70s, osteoarthritis, hip surgery, low friction torque, smaller heads. His dislocation rate in 70s and 80s was less than 1%, 2%. And everyone who trained in Wrightington didn't see a high dislocation rate despite having trochanteric osteotomies, despite having only 3 or 4 implants to choose from, both for the socket and for the stem. The dislocation was a meticulous surgical technique and it avoided it. The implants did well for most of the time, but having said that, these slides also speak truth that we saw cement disease, what the Americans called it, for well-fixed Charnley stem. There was problem with osteolysis and it affected. When I took the practice in 2006 in this hospital, the surgeon, senior surgeon trained in Exeter was doing Exeter stems. And he published his results 12 years in 2007 JBJS. And the 12 years pictures of lot of stems showed this picture. So decade on, we saw even hypertrophy of the femoral bone in 10 to 15% of the patients. So selection of implant did change what we will be facing, in future. And in my own practice, where the choice is among these 3 or 4 implants I regularly use, majority of the patients who are having cemented stems, 15 years on, 12 years on, I have not revised yet an Exeter stem for loosening other than infection. No intraoperative complications of an Exeter stem. So these are the examples of sort of intraoperative fractures. If you look at the NGR data, again, that's what Ross is saying. Look at the data for Exeter, lowest number of periprosthetic fractures are noted in cemented stems. This is not too far for CPT, Cryle, and Furlong fully coated, but the management will be different. So in my own experience, an intraoperative fracture in a patient who I did uncemented about 8 years ago. 3 weeks, she said she fell, or I would think it possibly was an intraoperative. And this was managed by a cemented femoral revision because I felt that she has a good bone quality. I could do good cementation if reduction is good and there is no bone defect. And the canal is narrow. For me to put a minimum 13 or 14 millimeter uncemented stem, I have to go through more steps. And this hip replacement was done about 8 years ago, and she is doing well. So what options we have currently in my hospital and majority of the hospitals in UK, we still have cemented long stems. We have uncemented long stems, which usually deal with the diaphyseal, metaphyseal bone loss. And we have situations where the bone loss is really bad and affecting whole of the femur, and cases where there is infection. Similar case, uncemented stem, chorial stem done some years ago, infection leading to infection. For me is a good indication for using cemented stem. You can add antibiotics to treat infection, and you could put a definitive stem. So in my practice, in my hospital, we have on the shelf conical stems. I'm not going to talk too much because I'm talking about cemented. Having said that, these options are the most favorable option currently. So this is what we saw in our practice. Stanmore, widely done stem in 70s and late 80s, leading to osteolysis. Uncemented stem can deal with diaphyseal, metaphyseal problem in majority of the cases. In type 3, 3A, and some extent type 3B can be converted to 3A with the use of allograft. And if the stems are well fixed, obviously you see good outcome in terms of bone remodeling proximally. We also keep HA-coated long stem with cannulated systems. It helps us dealing with, again, low-grade infection, diaphyseal bone loss, multiple fractures or multiple surgery in the past where we feel the fixation will be difficult and it has to be superadded with the cannulated screws at the distal end. Stanmore implants on the shelf to deal with complex type 3-4 cases, infections where we think it is better to take the bone away to deal with the infection, as excision of the bone probably in infection is critical to clear the infection. But they come up with more issues dealing with the instability because the Paprosky classification doesn't talk about the muscle attachment, doesn't talk about the soft tissues when it comes to deal with the fractures management. The paper in 2005, I wrote along with my colleagues, which looked at the practice of Professor Paprosky. At that time, we presented a case series of about 38 patients.
Recording in progress.
To log in before we finish Dr. Shahzad's talk, and then we'll just finish off with question and answers. I think we're just.
Yeah.
There's Ross. Hi, Ross.
Hey, what happened there?
Sorry, some technical issue. We'll just finish after this talk, and then a couple of question answers left.
Hope it's not too late for you, Ross.
It's getting late. It's 9:30.
Oh, 9:30.
At least you had dinner, Ross, I hope.
Is Dr. Shahzad also here? Can we have him finish?
I have just spoken to Shahzad, and he's going to reconnect so that he can conclude. We'll have a couple of question answered, then we'll conclude in next 10 minutes.
Yeah.
That would be fine, I think. Yeah.
So while we are already recording, so instead of just waiting for Dr. Shahzad, can I just ask Ross, what is the role of impaction bone grafting if you're going to be revising? Will you do a Paprosky 3-4 revision without impaction bone grafting, or will you always impaction bone graft?
To be honest, we don't see it that much anymore. Using exeter stems and uncemented stems don't tend to fail with that balloon osteolysis, so we don't do a lot of it. But again, it depends on, a super old person with a Paprosky 3 or 4 I'd cement, or, we'd do a conical sort of reconstruction. But anyone who's got longevity, I'd impaction graft. Yeah.
Great. Okay. So, Dr. Shahzad, can we finish your talk before we take this question again with the faculty?
Shahzad, you can share the presentation.
I don't know how much how many slides were.
Last few slides of the presentation.
Last couple of slides.
Well, my consensus is that yes, the impaction bone grafting technique is outside certain center, is not being regularly performed. So I myself, in a significant bone loss, will not be going for impaction bone grafting in significant bone loss, and I would opt for uncemented stems, to be honest. But having said that, if I feel that the patient is frail, there is osteopenic bone, and we can manage with a cemented stem, in my view, it is a safer stem for many patients.
Okay, so can we just do the question and answer sessions if you by and large summarize? Okay, Dr. Mohanty, sir.
Can I ask a question to Rosh?
Yeah, sure, sir.
Rosh, how often do you use long cemented stem? And what is your indication?
I don't do a lot of revisions anymore because the problem with doing exeter stems is you don't get a lot of revisions. But I'd rather use a long cemented stem than a long cementless stem.
It's a good problem to have, Ross.
Yeah.
Yeah.
Yeah. So
the long uncementless stems, you can have problems that diaphyseal fit. So yeah, if we got to go long, we'll cement.
So we don't have Dr. Fatih right now. Dr. Mohanty sir, what was your take on a Paprosky 3-4 stem, 3-4 femur? Would you do an impaction graft in a cemented hip, or would you do an uncemented femur revision?
I have not done a impaction grafting. I have not been trained for that, but I just see the literature. Very, very few surgeons do impaction grafting all over the world as well. So I would go for a long uncemented stem, maybe a locking type of stem, or a Femur type prosthesis. There are only these two options are available for us. So the other options, of course, that impaction bone grafting or doing a alloprosthesis composite. Unfortunately, we don't have a bone bank which provides allograft here in Mumbai, and there are other centers like Colin Institute. They are doing alloprosthesis composite.
So we do a fair amount of acetabular impaction grafting, not a whole lot of femoral impaction grafting. So would it be fair to say, for the benefit of the audience, that you need to reconstruct the tube, whether you have a periprosthetic femur fracture or a revision femur, and then if you're doing a cemented implant, it's better to impaction allograft. Yeah. And if you do not have the training, or if you do not have the facility for impaction grafting, then I think doing an uncemented distal fixing stem with or without distal fixation with screws is probably the way to go. And in some cases, you might need to do allograft composites or proximal femur replacements in these cases. So would that be a fair message for the audience?
Yeah, that would depend. So sometimes we have added fibula, we have taken fibula, we have split the fibula and done a surplus wiring around the stem.
So supporting the reconstruction with onlay grafts.
Yeah. I will just add one thing, that you have to see what problems are you dealing with. So the reason I'm going more uncemented or excision of the bone, which is a questionable living bone, is the fact that majority of the patient has a low-grade infection, and that is the situation I'm seeing 3 and 4 femur. Rest of the patients in my area, because we are doing axial cemented stem, they're doing pretty good. The ones we are picking up are those where we really have some issues with infection, and then it sort of contradicts to use a more bone graft in a questionable viable bone. So, and the procedure is obviously much quicker. If you have to put 10 femoral heads in a femur, it is too much in my view. But I am here to talk about cemented. So I do use cement as a temporary spacer to treat with those infections, to put more antibiotics into the bone.
Dr. Fatih, would you like to add anything to this, to the message that we send out to the audience? When would you do a cemented reconstruction and when an uncemented?
I think he's not connected to audio.
Yeah. Still, and Dr. Fatih has taken a leave. He has got clinical commitment. So he was here for 2 hours and he has taken a request. And
Okay, so before we just summarize, can we just do 2 quick questions? Maybe the first one from you, David. What would you give the salient cement handling tips for young surgeons? So those guys who are interested in learning and revising how to do a good, correct cemented femur, what are the cement handling tips that you would like to give to them? You're muted, David.
Using a gun is a good idea because it gets cement to most of the spaces. And getting good access is the next good idea. And using the trials when you put the rotors in gives you an idea of what size of implant you're going to use. And don't worry too much, because you don't really need to fuss about a complete cement mantle. Where polished taper stems are concerned, that is not necessary. All you need with a good polished taper stem is you need a ring of cement at one point around the stem. That's it. You have that, it will last. And if you don't understand what I'm saying, look up Ross Crawford's paper. Actually, Ross, you should have a session just on that one time, okay?
Ross, any points you wish to add on good cement handling tips before we just take another question and call it a day?
Yeah, look, the bottom line is it's actually really easy. I could teach you to cement in an afternoon. It's a myth that it's hard. And You mix your cement, you put it in a gun, you put it in the femur, and you put your stem in. If you can't cement a stem, you shouldn't be an orthopedic surgeon. It's so simple. And I think a lot of people make this myth that it's difficult to try and make an excuse not to use it. But, it's the easiest thing you do.
Okay.
So don't be afraid of cement.
So while the bulk of the message that you're giving out to the audience is that cemented hip arthroplasty really just needs a cement mantle around the femur, what would you think is the role of the so-called evolution of the generation of cementing techniques leading up to the fourth generation?
Again, this is all American. Americans love the next generation. Fourth generation vacuum mixing because you can sell more vacuum mixers. It's all product related. You mix it, you put it in a gun, you pressurize it, you put the stem in. And everyone's mythologized, made it a myth. And as to David's point, you want to do a good cementing so you can do cement and cement, so you can have a cement mantle for life. I tell my patients their cement mantle is theirs for life. If they're 20, it'll be there when they're 100.
If you look up Vic Johnston's series, it was on the first generation of Charlie hips, and it's religiously reported by John Callaghan every 5 years. I think it's got to 30 years now. The results are stunningly good. They're better than anything else you can find with any other generation of cements. And so I would say that if you have good cementing technique, and that's not necessarily the best, just good, okay, you have a good implant that doesn't break, which it did in those days, then you're going to end up with pretty good results. This is very, very forgiving.
Finally, to round it off for the young surgeons, what are the salient features you would advocate, Ross, for surgeons who are setting out to do a good cemented total hip?
Read a book. Get your local rep to show you how to do it in a sawbone, and don't be afraid. It's actually easier than doing an uncemented hip, in that you're less likely to have a complication in the short term with a cemented hip than a cementless hip. So just give it a shot.
The take-home message from me is, with a cemented polished tapered stem, you are fitting the implant to the patient. With an uncemented stem, you're fitting the patient to the implant. That's a lot of hard work.
Dr. Mohanty, sir?
One important point is to control the theater temperature. That is important. Control your theater traffic while doing a cemented hips. Use a good cement where you will get a good working time, like Palaka cement. I always prefer Palaka's cement because you get a good working time. The cement loses its viscosity first, but it doesn't set quickly. So get good at least 5 to 6 minutes of working time. And, plan your steps that you clean the canal, pack the canal, then mix the cement, load onto the gun and the series, then do distal to proximal filling and keep it pressurized, then cut the nozzle, then pressurize the, femur, learn the pressurization techniques that how much you have to have a pressurization, at least 1 or 2 minutes. Then while putting the stem, also keep your thumb near the calcar and do a good pressurization. So I have been trained in right intent also. So we have been doing good cemented hips, but trained of course towards the uncemented now. But these are the tips how you have to do a good cemented hip. The first thing what the youngsters do is to do a bipolar arthroplasty in a fractured neck femur. That is the commonest case we receive in our casualty, and the cemented bipolar is the first thing which you do. So if you learn on your bipolars, then gradually go on to the acetabular side and do a cemented pressurization techniques on the acetabular side. Use a flanched curve with pods and all this, which will provide a good pressurization. So all these things will improve on your cementing techniques. And one cannot forget the cementing technique, even if you do uncemented, because it is a must that one has to learn the cementing techniques if you want to be a good arthroplasty surgeon.
Dr. Shahid?
Yeah, I agree with what has been said, but I do agree that over the years, in cemented hip, you have to think about, was the design more important or the technique was more important? So what polished taper stem showed that actually the design probably became more important and sort of overruled the surgical technique of cementing. And that is the experience, what we have seen all across the world. So if you listen to David Choon, he's a senior surgeon, he's saying a bit of cement is fine, proper cementation. We talked about cement thickness. That with Exeter stem, the design probably overtook the cementing surgical technique. But having said that, the question is how you have a bloodless cementation or bloodless canal, and then how best to pressurize. This is what we want to achieve. And that's where, again, the role of anesthetists come, that how they maintain low blood pressure. So in the centers like Exeter and Wrightington, all the anesthetists have been tuned to do at the time of cementing. Everybody take notice. It's not something talking here, there. There's a cement curfew for many reasons. For me, the reason for cement curfew is more to focus on cementing. So it is important. Suctions are important. But overall, we look that the implant polish taper is covering some of the issues of poor cementing as well. But the early failure, it is not covered by many other implants. We saw many early 10-year failures in capital hip, in CPT hip, which are very similar hips. But the Exeter's polished taper stem in original design has outperformed all of them in everybody's hand. And it is surviving and has got the best results. I don't know what stem is used in Australia, or they are using Exeter cemented stem, or they have their own version. But that is my experience.
I would like to add that apart from Ross, Exeter didn't pay us to say this.
Okay, so I think we've discussed a fair amount on this, and maybe your final opinion on this, Professor Shahid sir, and your concluding remarks.
Thank you very much. First of all, I'm extremely grateful to Professor David Choon, Professor Ross Crawford, Professor Mohanty, Mr. Shahzad Sadek, and my other colleague who have just left. It has been wonderful. And I feel that I must conclude that it is our responsibility to spread this information, the evidence-based information, which is lacking. And I feel it is our responsibility that we have not been able to transfer this to members of APOA. We are not talking about the North America. And I think short visitation to a center that routinely does cemented, and I think a traveling fellowship for arthroplasty surgeon would be great, where and most of the UK center do cemented total hip replacement. And this myth of what I've learned today is the design of tapered cemented is more important, and a good average cementing technique would suffice. It is not the perfection, it is the design of the implant. And this is the take-home message that we want to send. And on top of that, I feel that for surgeons who are performing revision hip, impaction bone grafting technique, we should be conducting workshop on impaction bone grafting. And availability of instrumentation for impaction bone grafting and devices for proximal femur and acetabular side availability is something that we should promote. Otherwise, it's going to be a dying skill, and these instruments will be placed in museum, unfortunately. So thank you very much. And again, Abhay, for conducting this webinar. I'm extremely grateful to all faculty. Thank you very much.
I would also like to thank our support staff, Dr. Meenakshi and Shrutika, and our mentors, Dr. Jamal, David, and Nico, for the support through these webinars. Thank you all.
Thank you, everybody. Thank you. Have a good time.
Bye-bye.
Good night, Ross. Thank you very much.
Good night, Ross.
Thank you, David.
Staying us with
David,
David, thank you. Shahzad. Mohanty.
Shrutika, Dr. Meenakshi, have we stopped recording? Yeah, I think so.
Recording stopped.